Bismillahirrahmanirrahim. On to the next session of our internal medicine U-World. So a 32 years old woman comes to the emergency department due to swelling of the left arm over the last 24 hours. The patient drinks alcohol 2 to 3 times a week and uses intravenous heroin daily. She has no other chronic medical problems and takes no medication. Temperature is 37.8 degrees Celsius, that is 100 degree Fahrenheit. Blood pressure is 105 by 62 millimeters of mercury and pulse is 92 per minute. Okay, then we have the blood pressure is low. Then we have the respirations which are 16 per minute. Chest auscultation reveals a clear lung fields, in normal first and second heart sounds. The abdomen is soft and non-tender. Examination of the extremities shows several needle marks. The left arm is erythematous and swollen as well as warm and tender to touch. There is no joint swelling and range of motion is normal in all joints. The patient is started on intravenous clindamycin. The next morning the swelling and pain are improved. Okay, but the patient reports feeling miserable. She has nasal congestion, nausea and abdominal cramps in addition to multiple episodes of vomiting and loose stools. Nasal congestion, nausea, okay. On repeat examination, the patient is restless and reports aching muscle joints. Blood pressure is 132 by 88 millimeters of mercury and pulse is 102 per minute and regular and respirations are 16 per minute. The lab results from the time of admission and 24 hours later are shown below. Like complete blood count is 0 hours. Okay, so this is at time of admission and this is 24 hours later. So hemoglobin has decreased. The platelet count has been normal kinda. The leukocyte count has decreased. The neutrophil count has decreased and the lymphocyte count has increased. Which of the following is the most appropriate next step in the management of the patient? And out of the given options, the best option of choice is option D, that is initiate the treatment for opioid withdrawal. Educational objective of this question states that common symptoms of opioid withdrawal include nausea, cramps, diarrhea, restlessness, rhinorrhea, lacrimation, myalgias and arthralgias. Examinations can show hypertension, tachycardia, mydriasis, piloerection and hyperactive bowel sounds. Low dose methadone with adjunctive medication is treatment of choice. Now, coming back to the discussion, firstly they have given us a table. The clinical features of opioid withdrawal. Clinical presentation: acute opioid cessation, dose reduction after prolonged use. The gastrointestinal symptoms include nausea, vomiting, diarrhea, cramping and increased bowel sounds. The cardiac symptoms include increased pulse, increased blood pressure and diaphoresis. Psychological symptoms include insomnia, yawning and dysphoric mood. Other symptoms include myalgias, arthralgias, lacrimation, rhinorrhea, piloerection and mydriasis. The management is opioid agonist, for example the methadone that is preferred, or buprenorphine can also be given. Non-opioid management include clonidine or adjunctive medications, for example antiemetics, antidiarrheals and benzodiazepines. This patient with a history of intravenous drug abuse presents initially with the upper extremity cellulitis, which appears to respond appropriately to clindamycin as noted by improved pain and resolution of leukocytosis. However, her new symptoms are suggestive of acute opioid withdrawal. Patients with opioid dependence typically develop withdrawal symptoms within 6 to 12 hours of the last dose of a short-acting opioid, with a peak of 24 to 48 hours after the symptom onset. Manifestations frequently include nausea, vomiting, cramps, diarrhea, restlessness, rhinorrhea, lacrimation, myalgias and arthralgias. Examination can show hypertension, tachycardia, mydriasis, piloerection and hyperactive bowel sounds. Although symptoms caused by the natural opioid cessation, that is not triggered by the administration of an antagonist, are not life-threatening, they can be quite uncomfortable. Low-dose methadone, a long-acting opioid agonist, is often used in combination with adjunctive medications for symptom relief such as loperamide, diarrhea, ibuprofen, myalgias, baclofen for the muscle cramps and clonidine for the anxiety, restlessness and hypertension. Under federal law, emergency medication management of the opioid withdrawal with methadone is permitted for up to 3 days if the treatment is inpatient and the primary disease is medical, for example cellulitis. This should not be confused with methadone replacement therapy for chronic outpatient addiction management, where regulations are different. The option A, that is administration of intravenous morphine. This was not the option of choice because intravenous morphine should not be used in the management of opioid withdrawal. It is a potent, highly highly addictive and short-acting opioid, and it is used and its use could be detrimental to the long-term goal of overcoming the addiction. The choice B, that is discontinue clindamycin. This is not the option of choice. Why so? Because the clindamycin can be associated with diarrhea, nausea, vomiting and anorexia. However, the patient's restlessness, arthralgias and history of substance abuse are more suggestive of opioid withdrawal. The choice C, that is initiate the intravenous naloxone. So, initiation of the intravenous naloxone is a potent opioid antagonist used for the patient with the opioid intoxication. It can induce rapid withdrawal and should not be used in those who have withdrawal symptoms, as it may cause acute worsening. Option E, that is flumazenil. So, it was not the option of choice because flumazenil is a benzodiazepine receptor antagonist and can be used in the instances of benzodiazepine intoxication, which typically causes depressed mental status with slurred speech, but it has no use in the treatment of opioid withdrawal. Choice F, that is Clostridium difficile toxin, test for Clostridium difficile toxin. So, Clostridium difficile toxin is typically infection typically occurs in the hospitalized patient with the antibiotic exposure and can cause abdominal cramps, nausea, and diarrhea. However, it is typically associated with leukocytosis that is resolved in this patient, usually develop within 5 to 10 days of antibiotic use, and it is unlikely to cause arthralgias. The next question, number 24. They are asking about a 65 years old man with the non-ischemic cardiomyopathy treated with furosemide. Non-ischemic cardiomyopathy, and it is treated with the furosemide, carvedilol, lisinopril and digoxin. Comes to the emergency department with palpitations. His last left ventricular ejection fraction was 35%. His blood pressure is 160 by 100 millimeters of mercury and pulse is 130 per minute and irregular. The lungs are clear to auscultation. The abdomen is soft and non-distended. The ECG shows atrial fibrillation with rapid ventricular response and non-specific T wave changes. The therapy with rivaroxaban and amiodarone is initiated with an improvement in symptoms. The patient is discharged home after 2 days and this new medication added to his initial regimen. 2 weeks later, he returns to the emergency department with a profound anorexia, nausea and generalized weakness. Which of the following is the most likely cause of the patient's symptoms? Among the given options, the best option of choice is option A, that is drug interaction. Educational objective of this question is stating that amiodarone can cause serum levels of digoxin, can increase the serum level of digoxin and cause toxicity in a patient on a stable digoxin regimen. Acute digoxin toxicity typically represents with the gastrointestinal symptoms, for example, anorexia, nausea, vomiting, and abdominal pain. Chronic digoxin toxicity presents with a less pronounced gastrointestinal symptoms but more significant neurological and visual symptoms, for example, changes in color vision, scotomas, and blindness. Now, here you can see in the discussion they have given us a table about symptoms of digoxin toxicity. The cardiac symptoms include life-threatening arrhythmias. Gastrointestinal symptoms include anorexia, nausea and vomiting, and abdominal pain. The neurologic manifestations include fatigue, confusion, weakness, and color vision alterations. This patient's presentation is consistent with the digoxin toxicity, most likely due to addition of amiodarone to his medication regimen. Acute digoxin toxicity typically presents with gastrointestinal symptoms, for example, anorexia, nausea, and vomiting, along with possible weakness and confusion. Chronic digoxin toxicity presents with less pronounced gastrointestinal symptoms but more significant neurologic, for example, lethargy, fatigue, confusion, disorientation, and visual, for example, change in color vision, scotomas, and blindness symptoms. Amiodarone or verapamil, quinidine, and propafenone increase the serum level of digoxin by interfering with the digoxin metabolism and can lead to toxicity in a patient who has previously been on a stable digoxin regimen. It is recommended that the digoxin dose be decreased by 25 to 50% when initiating the amiodarone therapy, with close monitoring of the digoxin level once weekly for the next several weeks. Option B, that is erosive gastritis. It is not the option of choice because the erosive gastritis can cause nausea, abdominal discomfort, and or mild anorexia. However, it would be unlikely to cause profound anorexia and generalized weakness. The choice C, that is gastrointestinal bleeding. It is not the option of choice because the patient's gastrointestinal manifestations are likely due to the digoxin toxicity. There are no symptoms or signs of, for example, hematochezia or melena suggestive of gastrointestinal bleeding. The choice D, that is mesenteric ischemia. This is not the option of choice because the mesenteric ischemia presents with a severe periumbilical abdominal pain. which is often out of proportion to the findings on the abdominal examination. Although this patient does have risk factor for developing mesenteric ischemia, for example, the atrial fibrillation and severe cardiomyopathy, he has been on anticoagulation with rivaroxaban and does not have the typical clinical presentation of mesenteric ischemia. Choice E, that is occult carcinoma. It is not the option of choice because occult carcinomas are a frequent cause of the new onset anorexia in the older patients. However, this patient does not have specific symptoms to suggest malignancy, for example, the weight loss, increased abdominal girth, and gastrointestinal bleeding, and his symptoms seem to be temporarily related to the seem to be temporally related to the medication change. The choice F, that is pancreatitis, it is not the option of choice because acute pancreatitis presents with nausea, vomiting, and epigastric abdominal pain radiating to the back. The patient does not have typical symptoms of or risk factors for developing pancreatitis, for example, alcohol use, gallstones, or hypertriglyceridemia. The next question number 25 is a 60 years old man comes to the office due to edema on his face and ankles for the last 2 weeks. He has had no chest pain or breathlessness. The patient has a 15-year history of type 2 diabetes mellitus. Okay, so face and edema for the last 2 weeks. The patient has 15-year history of type 2 diabetes mellitus, which is currently managed with exercise, dietary modification, and glipizide. A month ago, his glycosylated hemoglobin level was 6.9%. Temperature is high, blood pressure is also high, and pulse is 75 per minute, and respirations are 15 per minute. Physical examination shows periorbital edema and bilateral pitting edema around the ankles. Then we have the remainder of the examination is normal. The laboratory studies are as follows. Serum sodium level is 140, potassium level is 4.3, bicarbonate level is 20, the blood glucose level is 120, BUN is high, creatinine is also very high. I guess bicarbonate is also deranged, but I'm not sure about that. The total cholesterol level is 300 milligram per deciliter. The patient's there is maybe some abnormality with that as well. So the patient's electrocardiogram is normal. And let me check that. Total cholesterol. So the total cholesterol level, the normal range of it is about 200 milligram per deciliter. So I guess it is normal. And total bicarbonate. It is 22 to 32. So bicarbonate level is low. The level of bicarbonate, that is kind of low, but the cholesterol level is within range. Then the patient's electrocardiogram is normal. Urine protein is 3700 milligram per 24 hours. Okay. Then which of the following measure is most likely to cause the progression of this patient's kidney disease? And among the given options, the answer of choice is option C, that is intensive blood pressure control. Educational objective of this question is the strict blood pressure control, particularly using the ACE inhibitor or angiotensin II receptor blockers, can reduce the progression of diabetic nephropathy. Tight glycemic control with target hemoglobin A1C less than 7% can prevent the progression of diabetic nephropathy. Further lowering is associated with an increased risk of hypoglycemia and possible cardiac events. Now here you can see in the discussion that the patient has long-standing type 2 diabetes mellitus complicated by significant diabetic nephropathy. Initially, the diabetic nephropathy is characterized by hyperfiltration, that is increased glomerular filtration rate. However, as the disease progresses, the GFR falls, manifesting as a rising serum creatinine level. Concurrently, the glomerular protein loss lead to the moderately increased albuminuria, urine protein excretion of 30 to 300 milligrams per day, previously termed as microalbuminuria, and eventually severe increase in albuminuria, that is more than 300 milligrams per day. As in this patient, advanced diabetic nephropathy can present with frank proteinuria, and nephrotic syndrome. In addition, with the type 2 diabetes, intensive blood pressure control is associated with a reduced progression of the diabetic nephropathy. The ideal blood pressure is uncertain, although a target of less than 130 by 80 millimeters of mercury is reasonable and achievable for most patients. ACE inhibitors and angiotensin II receptor blockers are preferred antihypertensive drugs. These agents lower the systemic blood pressure and also reduce the intraglomerular pressure, which may be renoprotective. The choices A and B, which are aggressive lipid management and aspirin therapy. Both of them were not the options of choice because intensive lipid control with statins can reduce the risk of coronary heart disease. However, lipid lowering therapy has not clearly been shown to reduce the progression of nephropathy. Low dose aspirin may reduce the incidence of cardiovascular events, but would not slow the progression of nephropathy. The choice D, that is intensive glycemic control with the insulin. Intensive glycemic control without glycemic management to a target hemoglobin A1C of less than 7% can slow the progression of diabetic nephropathy. However, this patient has a good overall glycemic control, A1C of 6.9%, and further lowering of the associated with an increased risk of hypoglycemia and may actually increase the risk of cardiac events. Although sodium glucose co-transporter 2 inhibitor also reduce the risk of kidney disease progression in this patient with type 2 diabetes with nephropathy, these drugs can also be used in patients with estimated GFR of more than equal to 30 liters per minute per 1.73 meter square and are limited in use due to cost and adverse effects, for example, the urinary tract infections. Then the choice E, that is very low protein diet, it is not the option of choice because a moderate restriction of the protein intake, that is less than 1 gram per kg per day in patient with a type 2 diabetes mellitus, may slow the progression of diabetic nephropathy, but the benefits are small. Very low protein intake is not advised because the patient with the diabetes often have some degree of protein wasting at baseline and additional complex dietary requirements are also there. Then the next question is question number 26. They are asking about a 32 years old woman comes to the office because of a 32 years old woman comes to the office because of fatigue, progressively worsening shortness of breath, and swelling of her feet. The patient has had these symptoms for the past 4 to 5 days. She denies chest pain. The patient has no other medical condition except for a cold 2 weeks ago. She takes no medications and temperature is high, that is 36.7 degrees Celsius. Blood pressure is low, 110 by 65 millimeter of mercury, and pulse is high, 90 per minute, and the respirations are also high, that is 20 per minute. Physical examination shows bilateral basilar crackles, elevated jugular venous pressure, and 2 plus bilateral pitting edema extending above the ankles. Okay, complete blood count reveals no abnormalities. Which of the following is the most likely shown on cardiac echocardiography? And among these given options, the best option of choice is option D, that is dilated ventricles with diffuse hypokinesis. Educational objective of this question is viral myocarditis is a potential cause of dilated cardiomyopathy in relatively young adults, for example, the age less than 55 years. Patients usually present with a decompensated heart failure that is often preceded by the viral prodrome. Echocardiography typically shows biventricular enlargement with diffused ventricular wall hypokinesis. Then the discussion is stating that viral myocarditis, the clinical presentation is relatively young adult, age less than 55. Viral prodrome, for example, fever, malaise, and myalgias. Heart failure, for example, dyspnea, orthopnea, and edema. And there will be chest pain and sudden cardiac death. The diagnosis is based on the ECG. ECG will be non-specific. Echocardiography will show a 4-chamber dilation. The cardiac MRI, late enhancement of epicardium will be there. And biopsy will show lymphocytic infiltration, viral DNA or RNA. The treatment is medication, for example, diuretics, ACE inhibitors, beta blockers, temporary ventricular assist device if needed, and heart transplant if no recovery. This patient has evidence of decompensated heart failure that is most likely due to viral myocarditis. This condition is most commonly affect the relatively young adults and is often preceded by a viral prodrome, for example, upper respiratory symptoms and enteritis. Most cases of viral myocarditis likely remain clinically undetectable, but some individuals may have a genetic predisposition that allows the viral infection, for example, the Coxsackie virus, adenovirus, parvovirus, to persist within the cardiomyocytes, causing the disruption of myocardial contractility. With progressive biventricular contractile failure, there is compensatory eccentric hypertrophy and the eventual development of dilated cardiomyopathy. On echocardiography, the dilated cardiomyopathy is recognized by the dilated ventricular chambers and diffuse hypokinesis of the ventricular wall. Treatment of dilated cardiomyopathy due to viral myocarditis is mostly supportive and involves the medical management of heart failure with reduced ejection fraction, for example, diuretics, beta blockers, and ACE inhibitors, with some patients experiencing eventual recovery of the cardiac function. The choice A, that is aortic valve vegetation, it was not the option of choice because the bacterial endocarditis of the aortic valve can cause aortic regurgitation leading to dilated heart failure. However, fever and leukocytosis are expected with bacterial endocarditis. The choice B, that is asymmetric septal hypertrophy, this was not the option of choice because asymmetric septal hypertrophy characterizes hypertrophic cardiomyopathy which is unlikely to present with a dilated heart failure. Hypertrophic cardiomyopathy often presents with a sudden cardiac death in patients with prior symptoms. The choice C, that is concentric left ventricular hypertrophy. It is not the option of choice because the concentric left ventricular hypertrophy results from the chronic pressure overload, as can occur with symmetric hypertension or severe aortic stenosis. The choice E, that is mitral valve stenosis. It is not the option of choice because the mitral valve stenosis is typically recognized by a mid-diastolic murmur and opening snap. Patients can develop diastolic heart failure with mitral stenosis is unlikely in this patient with no known history of rheumatic fever. The choice F, that is segmental inferior wall hypokinesis. So this is not the option of choice because segmental inferior wall hypokinesis is typical of inferior wall myocardial infarction, which is unlikely in the absence of the chest pain. In addition, inferior wall myocardial infarction often predominantly affects the right ventricle and would not cause a pulmonary edema. The choice G, that is thickened pericardium with loculated effusion. So the thickened pericardium with loculated effusion is a thickened pericardium with a loculated pericardial effusion can occur with a bacterial pericarditis, often as a complication of untreated bacterial pneumonia. Affected patients typically are ill with high fever, tachycardia, and chest pain. The next question, I guess we can complete this. So the next question is: a 16 years old girl is brought to the office by her office after a day of fever, malaise, shortness of breath, and chest tightness and non-productive cough. She is a 16 years old girl. Okay. Her symptoms started after visiting a farm during summer camp. The patient says that she was feeding hay to the cattle and milking a cow to get farm experience. Her mother recalls that she got sick when visiting another farm several years ago, and it took her several days to recover after returning home. The patient has a history of eczema and her brother has asthma. The temperature is high, 38 degrees Celsius, 100.4 degree Fahrenheit. Blood pressure is normal. Pulse is 88 per minute and regular, and the respirations are very high, that is 22 per minute. Pulse oximetry shows 92% when breathing room air. The lung auscultation reveals bilateral fine crackles but no wheezing. Office spirometry shows decreased forced vital capacity, which is following. Decreased forced vital capacity is there, which are the following are most likely chest X-ray findings in this patient. So among these given options, the best option of choice is bilateral interstitial opacities. Educational objective of this question is: hypersensitivity pneumonitis, okay, is an exaggerated immunologic response that some individuals develop to an inhalant agent. Chest X-ray in acute disease usually reveals scattered micronodular interstitial opacities due to patchy interstitial inflammation. Chronic disease shows diffuse reticular interstitial opacities representing an extensive network of interstitial inflammation and fibrosis. Now you can see in this discussion they have given us a table about the hypersensitivity pneumonitis. So hypersensitivity pneumonitis, the etiology is it is an immunologic response to the inhaled agent, for example mold, animal or maybe protein, mold or maybe animal protein. In acute cases, the clinical presentation in acute cases is abrupt onset fever, chills, cough, dyspnea, fatigue and leukocytosis. Episode often recurrent and self-resolving. The chest X-ray shows scattered micronodular interstitial opacities. The chronic cases show progressive cough, dyspnea, fatigue and weight loss. Hypoxemia that worsens with exertion, and chest X-ray will show diffuse reticular interstitial opacities. The diagnosis is done by the pulmonary function test. PFT will show restrictive pattern and decreased DLCO, that is decreased diffusion, the carbon dioxide diffusion capacity of the lung. Okay, DLCO is okay. The DLCO decrease in DLCO is seen only in the chronic cases. Bronchoalveolar lavage, high relative lymphocyte count will be seen. Lung biopsy will show lymphocytic infiltrate, poorly formed non-caseating granulomas, interstitial inflammation or fibrosis that is seen in the chronic cases only. Treatment is remove the antigen exposure, resolve acute disease, and glucocorticoids or lung transplant will resolve the chronic disease. Then we have the discussion in DLCO means diffusion capacity of the lung for the carbon monoxide. The patient presentation with fever, malaise, non-productive cough, and dyspnea. Non-productive cough and dyspnea after visiting a farm is consistent with the hypersensitivity pneumonitis. Hypersensitivity pneumonitis is an exaggerated immunologic response to an inhaled antigen, mold, animal protein, and certain bacteria are common precipitating agents. Patients with a history of atopy, for example eczema or asthma or eczema, are more likely to develop hypersensitivity pneumonitis, and smoking decreases the risk of developing hypersensitivity pneumonitis, possibly due to blunting of the pulmonary immunologic response. Hypersensitivity pneumonitis can have variable presentation depending on dose and chronicity of the antigen exposure. Acute hypersensitivity pneumonitis present in the patient likely result from the relatively high dose acute exposure and present with abrupt onset within 6 hours symptoms, for example fever, malaise, cough and dyspnea. Hypoxemia is common and crackers are often present on lung auscultation. Chest X-ray is normal in some cases but usually shows scattered micronodular interstitial opacities presenting the patchy interstitial inflammation. Uh, Symptoms are self-limiting and resolve after several days with removal of the antigen exposure. With long-term, low to moderate dose antigen exposure, patients can develop chronic hypersensitivity pneumonitis. The chest X-ray revealed diffuse reticular interstitial opacities which represent an extensive network of interstitial inflammation and fibrosis. Chronic disease is often irreversible. Pulmonary function testing in both acute and chronic hypersensitivity pneumonitis show a restrictive pattern. Chronic disease also demonstrates reduced diffusion capacity. Then the choice B, that is bilateral pleural effusion. This was not the option of choice because the bilateral pleural effusion are often seen with a low volume, with a volume overload, for example, decompensated heart failure, renal failure, or condition with a widespread and intense pulmonary inflammation, for example, multifocal bacterial pneumonia. However, the pleural effusions are rarely present with hypersensitivity pneumonitis. The choice C, that is enlarged heart contours. This was not the option of choice because the enlarged heart contour is seen with a pericardial effusion or decompensated heart failure. The pericardium and the heart are not significantly affected with the hypersensitivity pneumonitis. The choice D, that is hyperinflated lung fields. This was not the option of choice because the hyperinflated lung fields are seen with the air trapping that occurs in the chronic obstructive pulmonary disease or asthma exacerbation. Hypersensitivity pneumonitis is associated with a restrictive rather than obstructive pattern, therefore air trapping does not occur. The choice E, that is upper lobe infiltrates with cavitation. This was not the option of choice because the upper lobe infiltrate with the cavitation can be seen with the reactivation tuberculosis. Alveolar infiltrates caused by the alveoli filling with the fluid are not typical of hypersensitivity pneumonitis and cavitation does not occur. So we will keep this session till here and we'll continue with the next question in the next session. Until then, Allah Hafiz, fi amanillah and take care.